think about the people that were involved in that last evening. Well, exciting times all around right now. We have a lot going on, much to cover today. First thing we need to do is do a roll call to see if we have a quorum, to see what business we can conduct with our minutes, et cetera, today. So Becky, are you on today, Becky Onspach?
She is trying to be Dr. Burke.
She's trying.
Yes.
Okay. Robert Bischoff. I'm here. James Gone.
He is also.
Trying to get on.
He's watching on YouTube.
Okay, James. Thank you. Katie, are you on? Katie Ellman?
She said she's gonna be a little bit.
Okay. Deb Lambert. Deb, are you on?
Deb is on, but she says she can't, she does not have the ability to speak on there. The link won't work for her to have audio, but she can hear you.
I resent it. I can't do anything else. They gave me the link and I resent it and that's all I can do.
Okay, I'm going to continue with the roll call, but if people cannot respond, then I'm going to file the minutes. But okay, Jennifer, are you on? Jennifer Lance, I see
Yes,
you.
I am. And that last link that Julie sent out worked to get on for me at least.
Okay, Steve McCaffrey. Steve, are you on? Dan, are you on? Dan Mustard. Judith, you are here. Jake Sipe, are you on? Margaret Smith. Megan, you are here. Hello, Kelly, I see ya.
Good morning. Good morning.
Hi. Okay, I'm going to go back and see if people have can talk to us now. James, can you talk to us now? Do you have audio? Okay. Well, since I have some people watching only, and they can't respond to a vote, I guess we could do hands up.
Or they can just send a.
I think I'm going to say we 1, 2, 3, 4, 5, 6, 7, 8. I think let's just file the minutes. I don't want any question about whether we had people or not. We'll file the minutes. Does anyone have any corrections or additions to the minutes? We're going to file them because I can't say we have a quorum this morning.
I do
Oh.
not, Dr. Burke. Nope.
Okay. All right, we will file the minutes and bring them up for the next meeting. Also, Becky, are you able to get on yet? Not sure. Okay.
This is Deb, and I'm finally able to get audio.
Oh, okay, you're on. Okay. We must have a squirrel in the system somewhere. I don't know. Our people here work hard to be sure our technology works, but it has glitches sometimes, so that's the way it is. Okay, we will postpone the election for the vice chair position that we have open also until next meeting. And then maybe
Is there
we'll
enough?
have
Is there a quorum up there?
what?
No quorum?
We're still don't have people that can participate. Let's just wait. I don't-
Okay, so just for information.
But it doesn't give me a quorum. So that's the problem.
Okay, so I just want to put Megan's name forward for the vice chair, just so. And then you guys can vote on it next month.
Okay, that's fine. All right. Let's do that next month. You're willing to serve?
Yep.
Okay. Let's put that on for next month. We definitely need people coming on to the Commission on Aging. So hopefully we'll get some confirmations of people that are sitting over in the governor's office and has to come through there. So we will wait on that. Okay. Aaron is going to give us the 2024 Community Assessment Survey for Older Adults results. Yes.
Good morning. For those that don't know me, I'm Erin Wright. I'm the Director of Access and Engagement with the Division of Aging. And today I'm going to be sharing the results of Indiana's 4th round of the Community Assessment Survey for older adults, which we conducted this past fall.
Aaron, before you begin, I'm sorry to stop you, but I just want to clarify something, and I don't know who needs to give this clarification, but I had a question a couple weeks ago as to, do we have a Division of Aging and what is happening in FSSA with the Division of Aging? It's an important part. We have to have a state unit on aging because of the Older Americans Act, but would somebody here clarify what's going on with the Division of Aging within FSSA?
So the Division of Aging still exists as it has. We have an interim director, which is Kelly Mitchell. She is also the director of the Division of Disability and Rehabilitative Services. They are still separate divisions under the FSSA umbrella.
Okay, so just to clarify, and I want this in the minutes, the Division of Aging exists within FSSA and has an interim director right now. I think there was some confusion because in years past, the Division of Disability and Rehab Services, we were together, the Division of Aging and that, and then they were separated. And now there was some question as to whether we went back to the way it was or whether it's still a separate entity, but has an interim director. So that was clarified, and I would ask that go in the minutes today, please. Okay.
Dr. Burke, may I ask if there are any plans for future changes that FSSA is aware of? I understand that the interim status that Kelly has today, but Secretary Robe has put out on a couple of occasions some comments about his intent with the Division of Aging. And so if there's any information that could be shared, I think that would be helpful for this group.
No, there are conversations happening, just planning for the structure of FSSA and our division in particular, but there's been no definitive decision made that I'm aware of.
Okay. All right. Okay, thank you so much. Thanks for the question, Deb.
And I
Sorry.
will, I had shared the organizational chart of FSSA. I will send that out to the members that shows
Where we are and who's
where we
doing
are,
what.
and Kelly as the interim. And
Okay.
so I'll send that out with the slides from today.
Well, I think there's so much happening right now, so many changes in the federal level, and we don't know exactly where we're going to be with the budget here at the state yet and so forth. So just to clarify, we are official. We're still where we need to be. Things are still operating as we need to. So I just wanted that in the minutes. So
I
thank
still
you.
go to work at the Division of Aging.
Thank you. Sorry for the
No,
interruption.
that's okay. So last meeting in January, Vanessa Convard presented on the Age Forward Indiana, our multi-sector plan on aging. And a key component of the development of the plan was the data that came from the CASOA survey. So we thought it would be good to actually share the results in more detail since we hadn't yet. So CASOA is a statistically valid survey of the strengths and needs of older adults. Okay, thanks. Okay, I'll keep talking. So as reported by older adults themselves, and it is administered through a research firm named Polco in conjunction with its National Research Center. So Indiana has previously conducted this survey. This was the 4th round. So we conducted it in 2013, 2017, 2021, and then in the fall of 2024. So in addition to a needs assessment being an Older Americans Act requirement related to the development of our state plan on aging, and local needs assessments are requirement for our area agencies on aging in relation to their local area plans on aging, it really serves multiple goals. It allows us to have information about the strengths and weaknesses in communities and the experiences of older adults based on the feedback we receive from older adults themselves. It allows us to look at specific needs in the community by community or planning and service area. It really gives us a sense of kind of what's going on related to the experiences of older adults in another way that we haven't heard from on a consistent basis. And the CASOA allows us, and we'll get to this a little further, but to look at, because this is the fourth time we've done this survey, we can look at our information over time as well as comparing to other areas across the country that do the CASOA survey. So the surveys were mailed to a random sample of older adult households. There were over 60,000 mailings that went out. In addition, there was an online option through Polko where individuals could go online and fill out the survey. We had an 8% overall response rate, which is similar to 2021 and prior years. There were 4,500, a little more than 4,500 completed surveys, which this was down from the last round, but the response rate was about the same. We did some oversampling in 2021. We administered the CASOA in partnership with the area agencies on aging. We provided funding through the COVID HCBS ARPA funds in this year's state grants for the AAAs to pay for a kind of a baseline level of the survey. And then some of the AAAs that wanted to receive either county specific or community specific data for their regions may have purchased some additional reporting and sampling, but all of the AAAs received a PSA version of the report. About 60% of their respondents have lived in their communities for 20 plus years. Little over half were female. About a quarter of them had household incomes less than $25,000 a year. This was down 10% from the last round of the survey. About 35% were lower income last round. 97% were non-Hispanic white. This was increased from last time. And for age, the majority fell in that 60 to early 70s range. About 3/4 of the respondents were fully retired. And about a third, little more than a third, lived alone. So this map depicts the distribution of the CASOA surveys across the country. So when we received our results, they were benchmarked both against prior year surveys, but also we can see where we fell in relation to the other surveys that were completed around the country. And I believe there are about 500 communities across the country that have utilized CASOA. We are one of the few states that do the statewide version of CASOA. Polko, the research firm, has indicated that they're seeing more interest, particularly from Older Americans Act lens of using CASOA because of this benchmarking capability. So the survey is divided into domains of community livability, and there are 6 dimensions assessed through the survey in addition to overall community quality. And each section discusses older adults' ratings of the community, participation in activities, and potential problems that they're facing in their community relation to each of those domains. And as I go through the slides, please feel free to stop and ask any questions. There are a lot of statistics available in the report. We only pulled out some key highlights, but I'm happy to share the full report after the meeting if there is interest. So as I mentioned, the survey is divided into those 6 domains. Measuring community livability starts with really assessing the quality of life of those who live there, ensuring that the community is attractive, accessible, and really welcoming to its residents. An overall community quality explores how the older residents view their community as a place to live and retire, as well as how likely the residents are to recommend and remain in their community. So respondents gave their community a score of 66 out of 100 as a place to live and retire. So essentially, 66 out of 100 rated their place as excellent or good. Most of the older residents surveyed scored their communities positively as a place to live and would recommend it. And this is trending similar to past results, though the question about the place to live and retire was actually down from prior year. So community design needs, this is looking at how livable a community is, whether it's how the community is designed and planned, the ability to remain in the home, maintain the home, accessibility around the community. And we saw an increase in the number reporting at least a minor problem with home maintenance, whether it's maintaining the home or maintaining the yard. We saw a slight decrease in access to safe and affordable transportation. So when we're thinking about the programs that are available and prioritization of limited grant funds, it's this kind of information that can help kind of shape our program design. The next domain of livability is employment and finance. And 56% of respondents positively reported on the overall economic health of their community. 40% reported problems having enough money to meet their daily expenses, which was down from the last round. And respondents reported similar problems building their skills for paid or unpaid work compared to last time, whether it's volunteer unpaid work or finding work in retirement. There were some questions related to social isolation and social connectedness, and the majority of respondents held positive perceptions of their overall health and well-being. Over half responded positively regarding the availability of preventative health services, whether that's health screenings, flu shots, educational workshops. Respondents did note potential problems in several areas. Minority respondents indicated higher percentages of problems accessing services than those non-minority respondents. And the graph shows the percent feeling lonely or isolated. And while we're up from where we were in 2013, 2017, we have come back down since 2021, which was reflective really probably of the social distancing and isolation related to COVID. The next domain, health and wellness, looks at potential problems related to everything from having enough food to eat to the ability to move about safely in the home. And some areas slightly increased, some went down. But again, when we're thinking about our use of grant funds and available services, kind of seeing the trends with these areas can help shape our program design. So information and assistance, this looked specifically at the quality of older adult services and the information available regarding older adult services, as well as some factors related to financial and other legal services. 56% of respondents felt that they were somewhat or very informed about services and activities available to older adults in their communities, which is comparable. 74% reported at least a minor problem knowing what services are available to older adults, and only 25% reported the availability of information about resources for older adults as excellent or good. And I know we've spent a lot of time, even in the Commission on Aging meetings, talking about awareness and do people know where to go? How easily can they navigate the system? And this, I think, speaks to that. Around 33% of respondents reported good financial or legal planning services, and about 42% gave good or excellent rankings to the overall services provided to older adults. The next one looks specifically at civic engagement, social engagement, and caregiving. Around 46% of respondents reported at least a minor problem feeling bored, reporting fewer opportunities for recreation, social events, or religious or spiritual activities. So this kind of ties in with the social isolation questions. Only 15% reported using a senior center in the last 12 months, in the last year. So this chart is a breakdown of the contributions older adults make either through employment, volunteerism, or caregiving, calculated for the state of Indiana. So in Indiana, the value of paid and unpaid contributions by older adults totaled around $26.3 billion over this 12-month period. You can see we had a spike in 21, and then we've remained relatively on target is where we were. Oops, next slide. This is hard to read, but I will share the slide. So through the survey as a whole, there were more than 40 challenges commonly facing older adults that were assessed by respondents. And these challenges were grouped into 17 larger categories. And in Indiana, the largest challenges were in the areas of housing, physical health, and information. At least 47%, which was up from 40% in 21 of older residents, reported at least one item in these categories being a problem over the last 12 months prior to taking the survey. Further, the CASOA survey reported that older adult subpopulations in Indiana with higher proportions of challenges and an increased need for intervention tended to live in lower income households, renters, or lived alone. And seniors at higher risk also tended to be minority populations. Older residents that are 75 years or older reported greater needs than their counterparts in the areas of housing, mobility, and independent living, but fewer challenges related to finance and healthcare. Just to highlight a couple of the factors related to those three highest categories. For housing, 27% of respondents rated the availability of affordable quality housing as positive. It was higher in 2021. And 40% of respondents reported problems with having enough money to pay their property taxes. And this is actually slightly lower than 21. For physical health, 64% of respondents reported that their physical health to be problematic. 63% reported the ability to stay physically fit as problematic, and over half reported maintaining a healthy diet as problematic, with nearly a quarter reporting problems with having enough food to eat, which speaks to the importance of the nutrition programs and services available. further diving into information about available older adult services, said earlier, 77% of respondents reported problems with knowing what services are available to older adults in their community. Again, kind of reiterating, and I've used this example many times, but often people don't know what's out there until they actually need to start looking for it, and then they're in a crisis. That was a quick high-level review of the survey. Again, I'm happy to share the results, and I wanted to spend a little time if there's any questions or reactions, but I wanted to, again, tie into how we use these results in our program development and planning. I already mentioned the Age Forward Together multi-sector plan on aging. We will begin working on the 2027 through 2030 state plan on aging here in the very near future. It is due to the Administration for Community Living about a year from now. So the results of the needs assessment will help build that. And then currently the area agencies on aging are working on their area plans on aging. They are due to the Division of Aging by the end of May. And there is a requirement in the development of their plan that they share the results of their needs assessment and gather public feedback on the development of their plan. So I'll just put in a plug to look for opportunities within your local communities to participate with the AAAs in their area planning.
Okay, comments or questions to Erin?
I don't want to brag, but I have to say CoAction has been doing an amazing job when it comes to housing. I mean, they have been partnering and they've been putting up low-income housing left and right up there. I mean, I am so proud of them because they have done so much to help, and they're not sitting back on their laurels either. They had bourbon and bingo, which we went to the other night, to help raise money. So they're not just depending on the federal government to, hand over money to them. They're actually making their own money too. And that's really important. So the area of aging is really working hard to make sure that they do what they need to do.
Judith, would you, just for everyone to be sure we know what are you referring to, which agency up there?
Oh, CoAction there for Northwest Indiana. So they take LaPorte, Porter, Lake,
This is the AAA up
the
there?
AAA. Yes, ma'am.
Area 1.
Okay, I want everybody to be aware.
It is the AAA, and they are really working very hard. I mean, they actually are raising their money to build housing to make sure that our seniors are having places to live. That's huge. Because it's not a small adventure. I mean, it's really, it's hard to do, and they're doing it.
Thank you.
Other comments, questions? Thank you, Judith. It's helpful.
Erin, thanks for sharing this. A lot of really good information. I'd definitely love to get a copy of it to really look further if you can.
All right. Yes, happy to do so. Thank you.
Okay, very good. We need some good news around the state. That helps. Things are changing. There's opportunities as well as challenges that are happening right now. We are in a time to find some different ways to go about things, I think. And you'll hear this from me all the time, we're having what academically would be called policy devolution as we move from federal level down to the state level, or really down to the local level, where a lot of action will have to be done. We're back to about 1800 and what we're doing in this country right now. The local level we don't have the infrastructure there. We're not used to doing it at the local level, but that's where the action is going. And I think that needs to be said more. I mean, we have growing numbers of older people. I mean, being at the top of the baby boomers, wow. I mean, what a place to be right now. And there's lots of us. And we've worked hard during our lives, most of us. We've been in the military, we've paid our taxes, we've done a whole lot of things, and we're getting older and we're having some needs. We've also put a lot of We've contributed heavily in our communities. We're not all an economic liability. I look over at Judith. I mean, if you look at investments, most of that's done by older people.
Sure.
So, and we have people here in Indiana, here with the Commission on Aging, by state statute, we're to look at the entire older population in Indiana. And we are to act in an advisory capacity to FSSA on some of our most vulnerable older adults, because we now have people living longer than ever before, and a lot of people are outliving their money. Well, we have to remember that people are people. We've contributed, we've lived all our lives. We need to be included in what's going on in how we're going about taking care of everybody. And you can't help it. I mean, throughout a lifespan, some of us aren't going to function real well in our later years. Some will function very well. We have a lot of valuable volunteers activity going on, all the family caregiving. It just goes on and on. But we need a more holistic view of what's going on and to appreciate people across the lifespan. We're not responsible for human beings and how they live across the lifespan. We know that babies need help, children need help. We have an adult, pretty independent period of life for most of us, not everyone. And now we have some later years, and we haven't figured out quite how to live with those later years yet. The multi-sector plan on aging helped us take a look at some of the things we need to deal with that. We need to not forget that. I was happy that we were able to do that in Indiana, and we need to keep some of that going, because we'll get a little bit more. I hope our legislature uses a little bit of this. Sometimes we do more ideology. We do stats on things, and we give our government agencies impossible tasks to do sometimes. So here we are, and we're kind of in one of those. I'll be real happy when we finally get some budget. We know where we're going here, so we can get going on some things. But I do think we are at the local level, and we need to be aware of that. I know I live in this little rural county up there, Tipton, just north of the Indianapolis suburbs, and the county commissioners are sitting there saying, we need more revenue, we need more revenue, we need more revenue at the local level. Okay. Folks, we got things to figure out. So anyway, all right. Thank you so much, Erin, for that information. And that will be the results of that will be sent out to the commission. Okay, thank you so much. Sorry, I kind of get excited about things sometimes. So anyway,
Really?
well, y'all elected me again to be doing this, so here we go. Anyway. All right, well, now we are going to hear about what's going on with Pathways, Office of Medicaid Policy and Planning. Thank you so much for coming.
Nope, it's my pleasure. I wasn't exactly sure what you wanted me to report out on, so I've got some slides, but I'm open for other topics, just so you know. I only think there's like maybe 5 or 6 slides, so.
Well, we're kind of in a wait and see mode.
A little bit, yeah. Well, and I do think the next time you invite me back, we're starting to get more, we're starting to get more data though, because of the regulatory reporting. So we just got the Q4, and so now we can start analyzing it quarter over quarter, and I should have more kind of like solid stats to share. But today I was just going to talk about some of the Pathways enrollment and what that looks like right now, and then the waiver slots and the wait list. So currently, Pathways, the enrollment, the total number of individuals enrolled in Pathways is 116,000, almost 117,000. And then off to the left there is how it's broken out by MCE. Anthem has the majority, with UHC closely behind and Humana not too far behind UHC, this is kind of normal. If you look at the other programs too, Anthem's, this is their home headquarters. There's name recognition. And so they do tend to have the higher enrollment.
I thought when we discussed this, that it was going to be just a random.
It does.
So then how does Anthem have more than?
So we do it, there's an algorithm. So there's first people can pick, right? So they may pick Anthem. If they did not pick, and it's usually about a week or two before the start date of their enrollment, then there's an algorithm that will auto assign them. So maybe they were with Anthem at some point, and their doctor's still in Anthem's network. That's like a point there for them to go to Anthem then. Or if they have no, past history with any of the MCEs, then it's a round robin. So it'd go to Anthem, or Anthem would be first on that round robin, then Humana, then UHC, and it just will go in that way. But if there's a history with one of these three, or maybe their DSNP is with one of these three already, then they kind of take priority for those plans.
But we can't put them in a DSNP until they're in a Pathways.
No, they can be in a DSNP. Yeah, anybody who is a dual can be in a DSNP now. So you have the under 59 or under 60 population.
Correct.
They can be in DSNPs, and then they can, they'll roll into Pathways already enrolled in their DSNP.
Okay, so when we're selling DSNP plans,
Mhm.
if we had a person that was available for Pathways, but was not in Pathways, before we could put them into a DSNP, we had to make sure they were in Pathways.
That's not exactly right. Anybody can join a DSNP at any time or stay in Medicare fee for service. But there's the alignment, right? You have to be in an aligned plan. So if they come in on an Anthem DSNP, they're going to be assigned to the Anthem Pathways Medicaid.
Okay, so let me try again. And I sell insurance, so that's how I know. We were told by our companies that if you were going to put them into a plan and they had to be in Pathways first, they had to be registered into Pathways first, then you could put them into a plan. So while we were putting our clients into plans, we had to help them call into Pathways and get them registered into Pathways before we could put them in a plan.
Yeah, I mean, Pathways is an auto enrollment. The only really main criteria to be in Pathways is you have to be on Medicaid and you have to be 60 and older. So those are the only two criteria that you have to really meet, and not be on a IDD
But not
program.
everybody was registered in Pathways when in December, October, November, December.
Right. But the DSNP, so today, if someone wants to change their Pathways MCE, they actually have to go through the DSNP. They have to change the DSNP first, and then we get a file from the DSNP provider or health plan. And then we go in and update the MCE for the Medicaid side to match whatever DSNP. So I feel like kind of what you've presented is kind of the reverse of what we do today. So they have to be in the DSNP. The DSNP is what drives what Medicaid MCE they're assigned to.
Okay.
And we can talk, after this, we can sit down and we can talk a little bit more about that. But that's how we have it set up today.
Okay,
Yep.
because I'm just telling you, when we went to a annual enrollment, that's how it was. That's what we were taught, and that's done by all the companies, not just one.
So all three, Humana, Anthem. Okay.
Yeah, because I contracted with all of them, and that's how we were taught we had to do.
Okay. I'll get with Kim, who is our director over Pathways. And so she's the one that puts the state Medicare Advantage contracts together every year and works with the Medicare Advantage organizations to get those signed. So why don't you reach out to me? Let me set something up for me, you and Kim, to sit down and we can talk. And then if we need to go back to our DSNP partners to clarify, then we will.
Okay, perfect. Thank you.
Next slide. And so this is the Pathways waiver enrollment. And this is, I think I've said it in these meetings before, so this gets very confusing for folks, but we have the Pathways program, which is the Medicaid managed care program for anyone who is 60 and over and has Medicaid and is not currently being served like on a program through the Division of Disability and Rehab Services. Then we have the pathways waiver, which falls under the Indiana Pathways for Aging umbrella. Okay. And so these are the individuals who meet, nursing facility level of care, but want to remain in a setting in the community and are going to receive the home and community-based services in their home. And so current enrollment for the Pathways waiver is 27,419. And the breakdown of how they're assigned. So United and Humana have equal amounts, but they're the higher two. And then there's Anthem that has 32%. So that's how the waiver is broken out by MCE. Next slide.
Just for clarification, so when you say there's 117,000 or thereabouts in pathways, 27,419 of those
Yep.
are in the waiver.
Correct.
Okay, thank you.
Can you remind us how many through state fiscal year 25, how many waiver slots there are available for the Pathways waiver?
Yeah, if you hang on, Kelly,
Okay.
it's like one of the next, I have the health and wellness numbers and I have the pathways numbers on the next couple slides.
Thank you.
So we still have a waiting list for pathways and health and wellness waivers. Individuals are invited off each month and we have a priority order. So there's priority status and non-priority status. The priority status are individuals transitioning from a nursing facility or a choice program or MFP. They may be on Money Follows the Person today. And then it's, that they've met that deadline for that service. So then we move them into pathways. So those folks all take priority. And then discharge from a hospital as well receives first priority. Then we have the non-priority individuals, and these are just the individuals that don't fall in one of those categories I just talked about. And we invite them off based off the level of care assessment date. So it's really hard we get a lot of calls that say, where am I at on the waiting list? And it's really hard for us to answer that with, clear 100% certainty because we don't know how many priority slots we're going to have to invite first. And then, so I will, on one of the slides, I do have, since we do it off the level of care assessment date, I believe for pathways, we're like into September. So if they went onto the waiting list in September, that's where we're at with inviting people off. And we've been, yes.
So assisted living is not one of the priorities people in assisted living now.
So we did do a grant, when we went live with Pathways, because there were lots of individuals in the assisted living that were doing spend downs and so forth. We just submitted a new waiver amendment to CMS. And so we did put some slots aside. And I didn't put that in here because it hasn't been approved yet, but we asked to put some slots aside for assisted living. So we will have a reserve of slots for individuals in assisted living that maybe now meet that criteria. So that will be in the new, and that was just out for public comment a few weeks ago. And hopefully we'll hear back between, now and 90 days from CMS with approval.
Thank you.
I'm sorry, did you say there's approximately a 6-month wait period?
Yeah, we're on for pathways, it's September. We just invited folks off with a level of care assessment date in September.
Okay.
So we've got, October, we'll probably be into October.
Okay.
Let's see, what's the date? So about April 15th is when we send the invitation letters out. So that will hopefully be into October by that time. I don't know that off the top of my head because I did. 500. Thank you, Kelly. 500. There's 500 reserve slots.
Should be clear that if it's approved, it is a priority category. So that is an estimation. So as long as there would be waiver slots remaining,
anyone in that priority category would have first access to any available waiver slots, even if it's the 501st, as long as they're available.
So so we've made that assisted living a priority category and the new.
It's folks that reside in assisted living.
Okay.
Then become
Eligible.
eligible and are.
Yeah, and that's
risk
that.
of housing insecurity.
Right, and that was, I think that's the, you know, those things, lessons learned, you know, weren't quite had our eye or didn't have the right information to understand how some of the assisted living was working. You've got people moving in, they're paying out of pocket until they've spent their money down. We didn't have a wait list prior to beginning of 2024. And so now we've put this reserve amount of slots aside. We've made those folks that live in assisted living who are paying out of pocket that are now eligible for Medicaid will now be one of those new priority categories. If CMS approves it, hopefully they will approve it. So that's in our waiver amendment that we just submitted.
Thank you so much.
One of the things that I think we find challenging with our waiting list is that we have lots of individuals who don't meet the Medicaid eligibility financially yet because they need the waiver for the special income limit. And we've got a lot of people who are, because prior to when we go with our new level of care vendor in July, there was a short form. So it was kind of more of a screener. Okay, you look like you would meet level of care. So we're going to go ahead and get you on the wait list. But then we go out and we do the full functional eligibility when their invitation comes and they aren't eligible when you do the full level of care. So we have moved to start doing the full assessment before we put somebody on a wait list, because we don't want, we don't, unless their status changes and they come back to us and we reassess. But, we have a lot of people who think they're going to get the waiver. And then when that full assessment is done, they're not eligible. And so with the numbers today for pathways, when we invite folks off the wait list, 30% of those are already assigned to MCEs. So those are pretty much a done deal and are coming into services pretty quickly. The other 70% don't have Medicaid and also need to have that full functional eligibility completed. And those are the ones that where we only see about 25% actually finish the process and are eligible and come onto the waiver. So we've got a lot of folks on the waiver that are on the wait list that, aren't truly eligible, but got on there through this short screener. And so, or when they come off the wait list, they don't follow through with the Medicaid eligibility part of it. And so one of the things we did, we were leaving those slots open for a long time. So what we've done is we've put in place now, they have to complete this whole process within 180 days of the date from the invitation. And if they don't, then they can request to be put back on the wait list at some point, but we recycle that slot. So the next person in line, we're going to offer that slot, invite the next person in line off, so that we're not holding up some of these slots that are just waiting.
I just want to chime in and say thank goodness, because I looked at that wait list in Indiana and I said, what is wrong with this state? Well, not all states were doing it the same way that Indiana did. So we really looked awful. I'm just saying that.
Yeah.
But, and so this clarifies.
Yep. And we're also, we have our level of care vendor that starts July 1, but we stopped using the short form. I think it was last month. I can't remember, Mark. Oh, not yet. Okay. The plan was to start using the long form now before July 1, so that we could make sure people should be on the wait list that are going to meet the eligibility. And again, people that you're changing these are human beings. The change in status happens at any time, at any place. And so they can always come back to be reassessed. Like the one and done is not the motto in the reassessment and assessment world. So I think we can go to the next slide. This is the health and wellness numbers. I I'm, Kelly's here, so if I say anything out of turn, please grab me, but I wanted to make sure that I was talking about wait lists. I didn't want it to all be about pathways because I know we've got lots of individuals that are 59 and under that are in assisted livings and also receiving services. And so obviously health and wellness waivers for individuals 59 and younger that meet that Medicaid financial eligibility and the functional eligibility. As of March, there was 4,600 individuals on the wait list. And then the invitations that we've sent off this year so far, January 500 invitations went out, February 611, and then March 180. The total number, I think this was your question, Kelly, the total number of approved slots from CMS is 16,127.
Can I ask, what is determining the number of slots available? Is it funding? Or
It's what we submit to CMS as our estimated like pop number, what we feel like financially and, doing a view of the landscape, what we can support in Indiana, then we send that to CMS. CMS supports that number. When we hit that number, we either have to submit another amendment asking for an increase. But where we're at right now, financially, we are not in a position to go back to CMS and ask for more.
and those financials are dependent on hours provided or hours requested?
Provided, it's based off of claims paid.
Okay, claims paid, but I'm kind of wondering, like, when hours are not getting approved and authorizations are getting cut and hours are getting cut to providers, I guess, what is driving that? Where are those funds going? Are they just to approve more people to have fewer hours?
Yeah, well,
So-
it's not to approve more people for fewer hours, but it's to right size. So any adjustments made to any service plan is based off an assessment. And the assessment drives then the dollars available for that individual.
And those assessments are based on,
They're based off of the inner REI tool that is uniform. It's actually our level of care tool. So it's uniform across really both DDRS, OMPP, and Division of Aging. We're all using the same exact tool.
okay,
And then for health and wellness, they will be also instituting, and this is part of our waiver amendment, but they will also be instituting a pediatric because the assessment we use is more of a home care.
Okay.
What needs or does the person have that to support them in the community?
okay. So I guess my concern is when the goal here is to keep people out of the nursing homes, correct? With these waivers, when these MCEs are providing, they may have been providing 25 hours a week or 30 hours a week, and they're now being cut down to 14 hours a week, pretty much across the board. How are people going to stay out of the nursing home with 2 hours a day? I mean, that seems a
So
pretty drastic
I
change
think
in a
there's a
nursing
couple
home.
things that we have to look at when we talk about waiver supports. The waiver is in place because it's supposed to be a lower cost option than going into the nursing facility. When that waiver amount exceeds what the average nursing facility rate is, then it's no longer cost effective. And so first of all, the assessment drives the amount of hours. If it looks like this is someone who exceeds their budget's going to exceed, then we need to talk about other options like structured family caregiving, which is still a waiver option, or adult family care or assisted living. So then, if assisted living's, still an appropriate option. And so we've got to look at, and then what other informal supports can we also look at to supplement that? So it is really a kind of a larger picture. Yeah.
Can I add to when you were talking about it, we talked about cost effective.
Could you come up so the people online could hear, please? Thank you.
Hi, Kelly Mitchell. I didn't want to interrupt, but when you're talking about cost effective, it really is at the federal level. CMS requires cost neutrality to utilize federal dollars for Medicaid waiver services. So when that average cost begins to exceed institutional care, then you're no longer in compliance.
So is this the average cost per person? So if I'm
So
going to
it's
the
an
nursing home,
aggregate.
So if
And
I'm-
to the point that you made, we are approved for a certain number of waiver slots that we have to indicate to CMS that we can financially support, that we have the resource and the capacity. The Medicaid financials are posted each month on our webpage. Expenditures are not decreasing. While you may see in certain one-off cases, those types of adjustments, as a whole, we're not reducing what we're spending in home and community-based services.
What Megan was trying to say is when, before Pathways came, she's seeing clients that were getting 25 hours a week help.
Correct,
Since Pathways has been here, they're looking now at 14 hours.
correct.
So the question is,
My question is, if we had 10 people on the waiver before who were getting 30 hours a week, and now we're approving more people to get waivers, but we're cutting the hours that each person is getting, essentially what is happening is we're allowing 100 people to have 1 hour of care.
We're
or
not
hours of
approving
care.
more people to get waivers.
Because what we are seeing in practice is many people calling where I had 20 hours
Yes.
and now I have 14.
Yeah,
But more and more people, this is a new waiver. I just got this waiver. I just got this waiver. And the new ones that are coming on are at a much reduced rate.
it's a larger issue
Okay.
than just the waivers as a whole. And we likely don't have enough time to discuss this today. But when you're referring to the needs assessment and you're speaking of personal care services on the waiver, what we've seen as we dug in, this isn't just a result of Pathways. And I think that's where I want to be clear. This isn't about Pathways. It is about implementation appropriately of home and community-based personal care services. That can't be skilled care. It has to be one-on-one, hands-on personal care services. It can't be companion services for attendant care. So we, in a lot of instances, what you're seeing in these reassessments is the hours are reduced because it's based on utilizing the actual and appropriate service definition. Now, there are other services that can augment that. Home and community assistance. There may be skilled care needs that would be available through home health, traditional Medicaid. But there needed to be, regardless of Pathways, a realignment of what is offered through waiver and personal care so that we're in definition and compliance really with federal standards for personal care services and what waiver should support.
Okay.
You were speaking my language too. We are swimming in new waters as a society, not just Indiana, but as a nation. How do we better leverage local support? How do we support families and communities? I speak to that as I've helped my mother, in her last years, and I'm the tail end of the baby boom. I shared that last month. So we can bookend it. We can bookend it. So I think that's part of this is a level set. And I just wanted to jump in because this really isn't about Pathways, those things happening. Pathways was a way to better manage, I think, ensure that we were coordinating Medicaid and Medicare where appropriate, those D-SNPs, and really looking at better managing the resources that we do have available. But budgets aren't being reduced for individuals so that we can serve.
Yeah. That money's already been.
So I'm gonna let you,
Yeah.
I'm gonna.
So that money's already been budgeted. So for example, we have 16,000 slots for health and wellness. We have already forecasted that we should be using all of those slots, at some average rate. So that the money's already set aside for it. Whether the hours are being reduced or not does not mean we can now bring more people on.
Okay, so you are using some algorithm to determine who is eligible for however many hours. per
Yes,
day.
yes. we are.
So is there a process that people can utilize as we're addressing people don't know what services or what to even look for or ask for if they're having their hours cut and reduced and they don't seem to have a reason?
So they can follow the appeal process that is usually in the letter that they receive
Okay.
regarding the number of hours now that they're approved for. So they can follow the appeal process. And we do take that process very seriously because, there are times where maybe the assessment wasn't absolutely complete. So when we grab the service plan, we grab the assessment, we take a look at the two, they don't match. I mean, this is very few and far between, but they don't exactly match. We need to go
And you're
back out and
talking pathways specifically or waiver as a whole?
pathways specifically.
Okay, because we have had many, many people come to us that they cannot get through when they are trying to talk to somebody at Pathways. They're not having great communication or return calls.
And is this like with their service
These are
coordinator?
the family members that are calling in, like
Okay.
the daughters, the granddaughters, the sisters. I mean, husbands that are calling in to determine, why did we get our hours cut when we've had this for 4 years consistently? And now all of a sudden, we've had this new Pathways since July.
Mhm.
And now our new care plan comes up and we're cut
Mhm.
almost in half sometimes.
And I will send this, I'll send it to you, but we have a Pathways general email box where this is where families anybody can email us. Those come straight to my team.
Okay.
We log them all. We figure out what MCE it needs to go to, and then we don't close it until there's resolution. So, I will get that email back out, and if you want to email on their behalf, we will take a look at it. I mean, it doesn't
Okay.
matter who.
Or
sends
they
it.
just need a better, I
Yeah.
guess, outlet because they're trying to contact the MCEs directly and they're not having much success and they're just
Yeah.
floundering now, not sure where to get coverage because they've had this and relied on this for years
Yeah,
just to be cut.
yeah.
Well,
So
and I think that also speaks to the fact that there's just an incredible communication gap. I mean, I cannot tell you. So this is Deb, and I work at Byron Health Center in Fort Wayne, Indiana. And I cannot tell you the number of different case managers we've had from all 3 MCEs. In fact, one of them recently came in and said, well, we're not even going to be doing case management anymore. In the future, Provari is going to be doing all of our case management. And so we get new people, incredibly inefficient. They come in, they meet our residents, and of course, our residents think they can do everything by themselves. Reality and what you think you can do are totally different things. So we've had to spend time, our team has had to spend time getting these people back on a system that they've been on because they've lived here, many of them, for a very long time. And I can assure you that most people in long-term care and assisted living don't actually improve over the course of time. That actually their ADLs decline over time. So, these waiver slots and all of this stuff is important, but I think we're 9 months into this thing, right? 9, 10, something like that. And so we're hearing all this data about all these waivers and waiver slots open, and I'm not sure where we come up with the number of 120 days to leave a slot open. That seems like a long time. I think most people that are trying to get Medicaid approved, they've got their paperwork ready. At least the people we work with, we always tell them what paperwork to get ready, what to have ready, and so that when they get that letter or when they get that phone call, they're ready to go. But when are we going to start getting data and information on, like, is this thing meeting any of the goals that it was rolled out to meet? And I tell you, I'm a little frustrated that you said that we're using what sounds like AI to approve stuff, because I specifically asked that question before this thing started, because there was a lot of hubbub about Medicare.
yeah, we don't use AI. That's strictly prohibited. I don't know where you.
Okay, well, so who's got these logarithms that you
Oh,
use?
the assessment is called the inter-RAI. That's what
Okay.
it's
Okay.
it's
So
a
anyway, all that to say, like, when are we going to start seeing information on, is this achieving any of the objectives? Because and I get that rollouts are hard, and I get this is we didn't do it in one section to really work out these bugs. We roll it out all over the entire state. It just,
So
it's
today you
it's
can go
frustrating.
out to the FSSA quality website, and you will see some metrics already posted. We are now also posting a performance scorecard for each MCE, and this isn't just Pathways, this is all 6 MCEs. So you'll be able to see who met their regulatory reporting requirements, who was assessed liquidated damages because of that, who was assessed liquidated damages outside of regulatory reporting. You can see who's on a corrective action plan. And so that is supposed to be posted around April 1st. I don't want to, because this is the first time we're posting it, so there may be some glitches with us getting it out there. But
Right.
there's
Is that
some things you can see now.
Okay.
Then the other data that we're collecting, and we've gotten the first 6 months now, and that's what we're analyzing right now. We're breaking that down. It came, all reporting for Q4 was due by February 1st. So we have been taking that data, we've been bumping it against other data, like the fee for service data prior to Pathways Go Live, and making some, analyzing for trends, and then going back and addressing that then with each of the MCEs. I will tell you, this has not been a perfect process anyway whatsoever. And the MCEs have not been angels through this whole process. So, but we are holding them accountable. They are required to pay, fines for not meeting certain things, which that started in October 1st, where we could start assessing fines and sanctions. We've got 2 of them on a corrective action plan right now for different things. We have sent out warning letters as well. And all of this are things that we're logging on that performance scorecard too. So
Where can we find that website?
it's the FS,
Well,
I don't know it exactly, but it's but it's FSSA quality metrics, I think is, if you put that in the search.
So can you bring that information to this meeting? I'd love to tell you how I have all day to swim around that FSSA website.
Yeah, well,
I don't.
unfortunately, I didn't have it today to present, but time that
Yeah.
I did at the
And-
beginning of my presentation, the next time I come, I will
Yeah.
should have better
And
data.
yeah, I'm just gonna, give a disclaimer that, I woke up hating my blankets today, so maybe it's just me and the mood I'm in. But I take care of people and not widgets or statistics. And I'm telling you that the lack of continuity of care in this program is adversely affecting our people. And that frustrates me more than I can tell you. And it's got to get better because it's not fair to these folks. You can write stern letters to these MCEs and you can put them on notice or whatever. But at the end of the day, there are human beings tied to each and every one of these slots that we're talking about. And we got to get it together. And again, I may not be in a real good headspace today, but I'm real frustrated.
Will you remind me, what provider are you with?
Do you want me to give my real one or a fake one so I don't get in trouble?
Yeah,
Yeah,
your
just-
real one, please.
Yeah, so I'm with Byron Health Center in Fort Wayne.
Okay. And you guys, so do you do assisted living and long-term
Yeah,
care?
I have 120 skilled and then 50 assisted living.
Okay. Okay.
And most of them don't have voices. And so I take the fact that I am their voice very, very seriously. And I'm frustrated on their behalf.
Yeah.
That's, how I feel as well. Like I'm right in there with the home health community. Like we provide home health services and we're having people call in like multiple times in a month to say, what are we supposed to do? How are we supposed to get care? Because my daughter works or my son works. I don't have anybody to be home with me, or I don't have anybody to be home with my mom, and they're getting their hours cut and reduced. And there's multiple people have been saying they just want us to die. They don't care about us. They just want us to die so they can save the money. And that is really, really hard to hear because like she said, these are actual people, not just numbers and statistics.
Yeah. And that's not, that is not the intent of the program anyway whatsoever.
But that's the result that's happening. This rollout and that is what is actually happening for the people and the people in our state. The elderly.
And those are the things that will never show up in your stats and your data. And that's what I'm sorry, I think that information somehow needs to be assessed as well. The stress level that is hitting our families, as she said, because of this is just, honestly, it's just off the charts. And I'm going to be still now.
Well, and you know, we participate and work with several of the trade associations that represent the different, so Indiana, the IAC, the Indiana Association for Home and Hospice Care, we are in constant contact with and have calls with. We're the Indiana IHCA Nursing Facility Association, where I have weekly calls with. And so, I mean, we are trying to do everything we can to keep our fingers on the pulse to know what is, you know, that we don't take the MCE's word that I'm doing a great job, because that's not, we have several different types of outlets that we're trying to tap into. Right now is the what we call CAPS, which is the individuals a survey on how they feel their services are, their satisfaction with services. So that's going on right now as well. So we'll have those results coming up, which is the actual, you know, information we get from those individuals. So we do have other methods of checking in and trying to make sure that we're staying on top of things. So again, I don't want to, I am taking everything you say, I'm absorbing it, and I empathize completely because of, you know, like I said, human beings all have to be supported differently. It's not a cookie cutter response, but we are trying to do, you know, we're trying to get everybody on the right track.
I just want to say, my guess is there's going to be more frustration and not less in some of the things that are happening right now. We're in a lot of turmoil. There's a lot of us, a lot of older people. We're going to need some assistance. And we've got to figure out a way. And I think families are going to have to roll up sleeves and figure out things they're going to have to step up and do. And I think we need to be honest about that and not be promising things that aren't there. And I think also we got people whose families cannot do it or don't have families, and we're going to have to figure all of that out. And it's a tough time for people. It's a hard time to be families taking care of people. It's a hard time to be providers. It's a hard time to be figuring out how to provide government services when voters are saying, I don't want to pay taxes. There's a whole lot of things in all of this, and I think it's going to get worse before it gets better. We'll probably have shouting matches going on at the very least. But we are in a time of change, and we're going to have, and I'm just going to go ahead and say this morning. Politicians should not be out there promising things that can't happen. I mean, you can't say, don't pay taxes, and then there'll be something there. There won't be anything there if we don't come together and figure out some ways we're going to take care of everybody. Now, I don't know what else to say on that.
I agree with you, but in the same respect, you know, we started all this with pathways and everything because it was supposed to be financially better for the state of Indiana to get people out of nursing homes because it costs so much and get them back into the community. We were told services were going to be exactly the same. They weren't going to get reduced. Everything was going to be great. That's not what's happening. And we're not picking on you. We're not blaming you. We're just trying to get answers for the clients.
Yeah, it's frustrating.
Yeah, we're trying to get answers for the clients. Is this the way the world's going to be? And is this how we have to explain to them the world's going to be? And is this, because that's our job and that's what we do. If that's what the world's going to be, then we need to know that. Communication wide through all of us, we need to know if that's what the world's going to be so we can explain that to them. So we can help them find other ways to get some care. So if they're going to only get 14 hours and that's your rule, regulation, whatever, then they have a chance to explain that to the client and say, hey, you know what, we need to help you find maybe some family or something else, but they need to know that. And right now that communication is not coming through.
Okay. I hear you, and I will take this back.
Thank you.
Do you mind if I ask what provider you're with? Do you mind if I reach out?
Yeah, I'm not the boss, so.
Oh.
you can call and ask her. but
What, I'm sorry, what?
It's New Horizons.
Oh, New Horizons, okay.
Yeah, and I'm not trying to put that down. It's a real thing, and that's what I'm trying to say. People need to understand and know. And I'm just going to go forward and say, you know, voters have voted for what we have going on right now.
We just would like to be able to communicate with the families because we're kind of the middle in between, and we are only able to say, well, you're only approved for this amount of hours. And we're hearing from them about what happened to all of our other hours. And we're not the ones deciding that they can't have it. We don't really have a reason why. But what we were providing before and what we knew before and what we were told from the MCEs going into this is that they were going to still have those. So I guess she's exactly right, the communication, we just need to be able to
Yeah.
let them know this is all that they provide now. This is all that the state is going to provide now. So
Yeah.
what else is out there?
Right. And we can do a better job of getting that communicated just across the board. Whether it's through the MCEs or through the state, we will do a better job of getting that information.
And
out.
I just don't know if there's like a divide or a disconnect between the state and the MCEs. That could also potentially be what's.
I mean,
driving this.
it's like any kind of monitoring, you only know sometimes what you know. But I can tell you, I am in the weeds with the MCEs. I meet with all of them every week, multiple times a week. Because this is a program, a human service program that, besides, let's take out the insurance piece of your regular medical benefits. This piece is the human service side that's supposed to be more non-skilled. But, the goal was to create higher health quality, kind of spread the spending out a little bit differently, use different buckets to keep people where they want to be when, as they age. And it is a learning. I mean, we have lessons learned almost every day, I can tell you. And there's things that, I know there was lots of things said before Pathways went live, but then we had to pivot when, we saw there was going to be a Medicaid shortfall. And so, those things change. Now we have a new administration and things are changing again. And so, our goal is not to lose sight of the person. It's not.
Yeah, and I certainly don't want to tell the messenger for the message. This started long before you
That's
got
okay.
here.
I can take it. I'm good. I can take it. Yeah.
No, but that's not the point, right? So, and this didn't start under this administration. This hot mess started under the previous administration. So I don't know that we can really point fingers at administrations. Granted, it may not be getting better, but this hot mess started. So, I think it's great that you're meeting with the MCEs. I would strongly, strongly, strongly encourage you to actually get a group of providers through the different spectrums of what the waivers serve and meet with them. Because, if you look at it, if I'm an MCE, am I going to sit in the room and give you all my dirty laundry? No, because there's literally hundreds of millions of reasons for me not to, because that's the fee I'm getting from the state of Indiana to run this program.
Yeah.
And I will also, and I believe this in my heart and soul, because the stuff that I hear, so one of those trade associations that you referred to, I'm on the board of one of those, and so I know the information that's getting there is, I think it's very filtered by the time it gets to the people that you sit in a room with. And so I'm just saying, at the end of the day, again, it's not widgets, it's people, it's not slots, it's people. And I really think I would strongly recommend that even if it was once a quarter, you sit down with providers and truly get their direct input, because I'm concerned that information is getting highly filtered by the time it gets to
Okay.
you in a meeting that you're sitting in. And I say that respectfully.
No, I mean, that's a very easy recommendation for us to go back and implement. So I appreciate the feedback.
Hey, you guys were doing that prior to the.
We still do. We
Okay.
still meet with different providers. But again, some of the provider groups we meet are through the association. So the association is pulling them together for us to meet with. So, we can probably do some outside of the associations as well.
Yeah, and I think, with all due respect, there's a couple of organizations that owned a large percentage of the nursing homes, and I know that they typically always have a seat at the table. And honestly, I'm not saying they don't have trouble, but they have the corporate office bandwidth to get those things fixed, or to have a seat at the table. I think it's the other percentage that don't have that kind of bandwidth that's really, um, I think they're worth talking to and they're worth listening to as well. So
Yeah,
thank you for
yeah.
listening to me and my frustrations
This is an
today.
easy recommendation for me to take back and us look how we can do something a little bit more. Do
You
you
know-
want to see the next slide, you guys? I go for it. I don't know if you want to go on. This was the pathways waiver stats. Now, you're gonna see that we invite a lot more people off the wait list than the health and wellness. We get a lot of this is not I don't want to say recycled slots, but we get a lot of folks that don't respond. So we have all these slots that we reprocess. And so we're able to take those every month, analyze like who didn't pick up their slot, and then repurpose it back out and invite more people off. And so we are inviting lots of folks off. I believe that we just sent out 2,800 invitations recently as like a one-off to try to, because we had a bunch of slots that did not get used. So
Those are the numbers of slots invited or people who took them.
no, those are what the invitations we sent out. So we have, I won't say that we have that many slots necessarily available. Like there's a percentage, variance that we use, but those are slots that we feel like we would have enough people respond, that we would have enough slots to put them into a waiver slot. Our total number of CMS approved slots is 39,842. And then when we resubmit, that number doesn't change, but when we resubmit, the CMS will reapprove that on the amendment that we just sent back in.
Do you guys have a record of how many actually accept versus
So
how many send out?
what I can tell you is just that for pathways, 30% of them are already with a MCE. So they are coming into services very quickly. And I'll let you talk. Yeah.
Since I'm always in the weeds. on
Yeah.
this. So the numbers that you see there, it is actually based on the number of slots that we have left available.
Right.
So out of the total number, 39,842. So we invite based on that each month. When we recently analyzed the throughput, so from invitation to now I'm on an active plan. If it been starting July 1 and we were looking at through December and January, only about 39% had gotten to active waiver status. That is why we made the decision then to implement that 180-day timeline. As you spoke to that very well earlier. So we had folks that we issued the invitation. They do have a window to respond, 30 days, but we were giving some grace there. But then after they accepted, they would linger. So they were just holding the invitation and they weren't moving forward. So to the point, we don't see folks moving quickly to Medicaid application. I think someone on the call mentioned that was their experience. That is not what we're witnessing. In fact, when we issued the 180-day, the first round of letters to folks that had hit that, and we gave additional grace to those that have been on since July, because we just implemented. So instead of 180 days, those folks had 240 days. I can't tell you the volume of folks that said, wait a minute, I just applied yesterday for Medicaid because they got the letter or what have you. So once we issue an invitation, we have promised that slot and we can't issue anymore. Right? We've told CMS we only have X amount of slots. So if we've issued an invitation, it's taken. I've said, Dr. Burke, you have a slot. Holly, you have a slot. If that person holds it and doesn't act, hence the need for a timeline to say, if you don't move to active waiver status, we're going to rescind the invitation and be able to reissue that. So about 40%. And what you see in March, 1,800, that's because of the first round of revocations. Because we were at capacity on issued waiver slots. So if that gives you any indication, the first round of revocations, 1,800.
Where do you get your, hold on, where do you get your financial information from? Because I have a client, I have two of them, and Leslie was gonna help me with it, but then things happened. But I have two clients that, one, they said that they get 3 incomes from Social Security. You all know that's impossible. And the other ones that they have 3 bank accounts and they only have one. We've sent in the information to Medicaid, showing that this is the only thing that we have.
So you're talking about the application for Medicaid
Yes.
financial to DFR, Division of Family
She's already-
Resources.
They both already have Medicaid qualified medically, but they're trying to qualify financially.
Yeah. Well, that is through the Division of Family Resources. Again, if there are particular issues we have, we have a Beats help email, you can elevate those. A lot of times I do get those through some of the trade associations. Actually, they elevate specific cases, but the individual should reach out to their local office and you can appeal if you think it's been
So
denied
they
in
get
there.
the letter, we send them all the information. I may fax it, I may mail it, but I always send it certified mail.
Yeah.
But then they get back pretty much the same letter that says, oh no, you have this kind of income.
So
That's all they get.
I think if they're pathways, you can email our pathways email box.
Well, they're not pathways
They're
yet.
not- Okay,
Well, because they're only qualified medically,
okay, so.
So
not
one
financially.
thing I would suggest, and I'm gonna speak to this update, but this is a now through the ADRCs or the AAAs, one of the services that they offer is Medicaid application assistance. And that's something that we support through the state. So if someone needs some assistance, because they can help them with the application, gathering of data, they can actually go to, I think, an initial appointment. I'm looking to Erin when you see me turn, because she is the subject matter expert. So it's a little bit more than call here, do this. They can get support from their local AAA. That is a service that's supported by the state and the funding that supports those aging and disability resource centers through the AAAs. Did I say anything inappropriate, Erin? Okay.
So I'm done with my.
Holly is so
presentation.
tired. I am so sorry for
Well,
popping up
I
here.
just used all your time or not.
Well, let me just say thank you. I think the passion that was demonstrated in the discussions today say people really want to take care of those who are vulnerable in this state. And that's where we are, and we're finding our way. This is not a magic bullet that just all of a sudden go to MCEs, managed care, and get this done. Some people thought, well, the government was bad, we'll go to the private sector and get it done. Well, we're all going to learn our way through all of this. And like I said, there's a lot of us coming along, and we got to find our way. We just know we all have to roll up our sleeves and figure this out. It's difficult, and thank you for sharing your concerns, because we need to keep the discussion going. And that's what we're here for the Commission on Aging. So thank you so much.
And I always say, we don't know what we don't know. So the feedback is extremely important. I will make sure Erin sends out my contact information too. So
And that email for people. Okay,
yeah,
thank you.
I'll have her send that out as well.
Thank you.
Thank you guys for letting me speak.
Thank you so much.
I
Thank
apologize. I don't know if Kelly's gonna speak or who answers. I have a two-part question. One, with regard to the waiting list, does the state have the ability today, if someone goes off of the waiver due to death or loss of eligibility, can we backfill that slot today with someone who is on the waiting list, or is that slot held until the end of the next, to the start of the next state fiscal year?
All right, well, you pulled Kelly Mitchell back up to the podium for that question. So CMS requires a non-duplicate count on waiver slots. So once a slot is issued or belongs to an individual, it belongs to that individual for the entire waiver year, and that runs July 1 to June 30th. So to the question that you ask, if someone is on a waiver and they pass away, that waiver slot is not available until a new waiver year starts.
Does the state have any ability to request a change in that with CMS? The flexibility to backfill that slot?
I know that they have looked into it in the past, and I'm going to speak to a lot of things that we're looking at strategically. I think we are looking at a lot of areas as it relates to waivers as far as service definitions. How might we, do those things better? How do we manage the waiver slots? And by the way, I hate the word slots, but it seems to be the only thing that when we speak publicly, it provides clarity. So I'm not saying no, we can't or we won't. I think it's just a cadre of things that we're looking at as we in this. I always say in the new waters, and I don't mean anything about administration. I think you've Dr. Berkman summing this up so well. In these current times, how do we best write policy, procedure, service definitions, waiver documents to support the outcomes that we want in the environment we're in. So,
Thank you. I totally agree that it's not easy to call them slots. These are people to.
yeah, I cringe every time I say it.
I know.
But I can't come up with anything else that really conveys it clearly because it starts to get confusing, so.
I know. Well, the second part of my question, Kelly, is that at Q4, at the end of 2024, under the previous administration, there were some comments made about the concern of running out of slots by the end of this current fiscal year. And that would be through the numbers of invitations sent. Kelly, do you still have any concerns that we will run out, we will be forced to discontinue invitations to either the health and wellness or the pathways waiver between now and July?
I can't predict that. What I can state, and you can see it. I mean, we post the number of invitations that are issued each month. Based on sheerly issuing invitations, we have already reached capacity on waiver slots. I want to preface that once again with, go back to my statement. Once I issue an invitation to you, until you become, as long as you're holding that invitation, I can't give it to anyone else, right? Non-duplicative. And so folks from the time of invitation have 180 days. That's the new timeline. But prior to just a month or two ago, there wasn't that timeline. So what you are seeing now is, as we resend, if you will, those invitations, if someone's reached the 180 days, or they've said, I don't want the invitation, or something else has occurred. I mean, sometimes people move out of state. Sometimes people pass away before they receive the invitation, or during the early stages of the invitation. So once that is rescinded or returned, then we are reissuing those. We'll see what that volume continues to be. March is evidence of that. There were 1,800 in pathways, and then whatever 180 or so in health and wellness. That's just a smaller population and number of waiver slots. So I don't know that we'll run out. I just don't know the volume that will be available.
Yeah, that makes sense. Thank you, Kelly.
Yeah. Now, do you want an update? I feel like I've given a lot of that. It's really odd because I don't like to read from scripts. And so I came down here with a blank piece of paper and I thought, what is it I want to cover today? I mean, obviously I knew, but as listening to all of you, and as you were speaking, and I've already said this to you as I walked up earlier, but you really are speaking some of what I wanted to share today. Kelly Mitchell and I am serving as the interim director for the Division of Aging. And my goal and what I've been charged with is really putting vision into action. And I think you said that we can talk about things, we can pontificate, we can say what should be, how it should be, what isn't working. How are we going to put wheels on it? How are we going to move things forward? That is where you will see me. I'm already starting to light up and talk about it because that's what I love to do. And that's what I've done my entire career. For those of you that don't know, and I think I've shared this, this is my 38th year in this industry. I came from the provider world a little less than 4 years ago to the state. I full well know, as does Holly, by the way. She also came from the provider world. We walked together for most of those years with different organizations. And so I'm very passionate about supporting individuals. But it is, how do we put that vision into action, and how do we leverage and engage local communities, right, in supporting Hoosiers as they age? We have to do this regardless of the economy, regardless of the waters that we're swimming in. Public dollars can't and will never fully support the needs that we have. So it's not only how do we best use the resources that we have from the state and the federal government, how do we leverage what exists within family, within neighborhood, what I call community. Community isn't a building, a place, a what have you. It is the circle that we swim in. And we need to do that better. I know I'm really big about engaging locally. The AAAs and our ADRCs are an integral part of that. And they're a big piece of what we do now within the Division of Aging. I also loved what you said, because one of the notes that I had before you spoke is the Division of Aging is the state plan on aging. It's state agency on aging, regardless of the structure. And I've told this to the internal team, and I hope they smile when I'm saying this, whether it's a standalone division or it's within another division, and I'm not saying DDRS, wherever it's at, the value of what is to be done exists, the value of the roles exist, and the value of the work exists. That's not going to go away, and that's not why I'm here. And as the interim director, and that's not a goal of this administration, is how do we do it? How do we do it better? We got to do it better. So in the coming weeks, here's what we're going to do internally after we allow Aaron to have a much needed vacation. And that is one of my first observations. This lady has a lot on her plate, as does Rebecca and several others. So we're going to sit down as leadership within the Division of Aging. And we're going to take that multi-sector plan on aging is really foundational, but really talk about the vision. What's the vision? What's the vision and the mission? And then what are the action steps? We need to frankly, do a better job of that. And that's not a condemnation of any of these team members here or anyone past. We just need to do a better job of that. We can research and study and surmise, but it's like, how do we actually support communities in doing this? So that's the outcome that I desire. So some of the work that we've already begun to do in preparation for that is we've been meeting rather consistently with the AAAs, is because they are the Aging and Disability Resource Centers. And as I've and others have looked at what we do through the Division of Aging, right, wrong, and differently, the fact of the matter is the bulk of how we support Hoosiers as they age in their communities is through the AAAs.
Amen.
That's how we're doing it. At least that's how we're doing it today. We need to figure out how to do that well. And we need to do that in partnership with the AAAs. And so that's some of, you're talking about coaction. I had a lovely meeting with them just last week too. They are doing some really exciting things. But what we need to do is bring folks to the table, and this is all that I've asked. Don't tell me what isn't working. Don't tell me what we need to do better. Don't tell me you have a problem and ask me how I'm going to fix it. Let's come to the table and talk about what do we need to do to support Hoosiers as they age. How do we do it together? I want you as a partner, I'm not going to hand you things to do and then you report to me.
See, and that's what I was trying to explain, that's something that they are doing right now.
Yes.
I'm very proud of them. I'll admit.
And that's
housing.
part of this engagement. That, it was, as I said, it was a lovely meeting. They shared with me what they're doing. They wanted to ensure alignment with where we're headed. And so one of the things that we have put forth to them is we're going to start with a work group to really talk about what next as we move into this next phase. I know everyone knows there's another change coming, level of care, LCAR, the movement to level of care assessment through a vendor, Maximus, that will be doing this statewide. We are still going to work through and with our ADRCs or the AAAs. Those are synonymous right now, but it really is through that Aging and Disability Resource Center. And I keep saying that because they're not just AAAs, Resource Center. I come from a local community. There's no one that knows better how to support someone than folks that are in the community. So we're going to look at them as we move toward another vendor conducting the level of care assessments. How do they support us? We're going to have a wait list, and it doesn't look like the demand's going to drop. So we're going to probably have a wait list for some time. So help us in really being kind of that not a wrong door. So people know they can go to the AAAs. They can help us manage the wait list. They can connect appropriately to pathways, warm handoff. They can support the folks that are non-waiver. That's going to continue because we have non-waiver home and community-based services. They can support individuals. I spoke to that medication application assistance, but we really want to enhance that. They haven't historically done a whole lot of that. And there are a lot of reasons for that. That's one of the biggest needs that I'm seeing. When I get pulled in and people say, help, this is a mess, 9 times out of 10, there's something with Medicaid financial eligibility, and it just needs someone to help coordinate it, pull all the pieces together. Not if you call over here, that's where you file that. So Aaron and other team members from the state, from OMPP, from DDRS, because all these things are linked, we're going to be meeting with those work groups over the coming months to ensure that on July 1, we have a new contract, because there's a contractual relationship that starts in July, that we have a contract in place to really support what we need, that we're clear about expectations and what it is we all want to happen. So I'm pretty excited about that. So once we have that vision, some of the work then is internally, how do we better structure the roles within the Division of Aging to support the work that we want to do? And Aaron knows that I speak to this a lot. As an outside person coming in, I'm like, I look at where the volume of your work is, and I'm not necessarily seeing the structure supporting that equally. So we've got some work to do internally. So that's part of my focus as well. And it's the focus of the Division of Aging. So we're going to keep everyone busy for a while, and we'll update you on that as we move forward. I think the last big thing that I will share.
Are you planning on reducing the number of AAAs in Indiana?
Well, I'm not planning that. In fact, wouldn't be something that we could do. I will say that I think the AAAs and their association recognize it's probably time for a reset and to modernize. I think it's a goal within the AAAs themselves. We would support them over a process of time. So there likely will be some restructure, but that wouldn't be driven by the state.
Okay. So it's not something that you guys are.
That is through and Aaron's the expert on this, but that is through the Older Americans, through Older Americans Act. It's really a very defined process as to how those local centers are established. And so
it said that they technically only need one.
Technically only need one what?
One area of aging.
Oh, I don't know that will ever be the case.
There is possibilities to go
Yeah.
Delaware.
Yeah.
Okay.
But there has to be local community engagement and involvement if there would be any remapping, if you will, and restructuring. As I said, I think it is a time to relook at it. And I'm looking at you because I think about cost, and we all know administrative overhead. There's only so much of that to go around. So I don't know what will come of that, but it can't and won't be driven by the state. what we decide to do may drive some of their movements. But local communities really have to be involved in any kind of redistricting, and it's a couple year process to do that.
There's a
2 years? Okay, yeah,
There's 16 planned service areas.
Yes,
in
16.
Indiana, and I think that's what you're talking about.
yeah.
All that would have to be changed, even though we have one AAA serving 2 planned service areas.
Yeah.
So,
Yeah.
however it happens.
All right.
So fair enough question. And I think the only other update that I had is just we are moving forward with the selection process for adult protective services. And so we'll do an update on that in a future meeting.
Do you
So
have
we're
any
getting
idea
close.
where that's headed?
We-
Where adult protective services is headed?
Yeah, well, all of that was out for request for proposal.
Right.
New vendor. So they are wrapping up that process now. And we should be able to report on that in a coming meeting.
So we hear all the gossip out there because we talked to everybody and they're saying that the state's not willing to pay as much as like the hub thinks that they should. So my understanding is they pulled their request out. The AAA hub.
I can't speak to anything around the
Okay.
request for proposal process until it's closed and awards.
Do you know
can't,
when that's going to close?
it should be very soon. I mean, we're in the final wrap days of that. So
So then is the prosecuting still going to leave in July? Or do we not?
yeah, I can't, yeah, because it's all an RFP process. I'm not really trying to not be
No, that's
transparent. I
That's
can't
just
because of
curious.
ethics and other pieces until that's all
Okay,
finalized. I can't speak to it. So my apologies.
that's
By May, we
but-
should know, I think.
Yeah, yes.
okay.
Any other questions? Aaron, Rebecca, is there anything that I should share that I didn't share?
And we all know Erin works from the bottom end off too much.
She does.
She
I've
does.
told her that was one of the first thing that I noted, and man, she is a wealth of information. So I've been drinking from not just one fire hose, about 5, trying to learn everything over the past weeks and month or so.
Well, thank you so much. We want to continue to have our updates from the Division of Aging and from OMPP and the Pathways Program, because we are by statute supposed to be looking at all of the input that concerns older adults. So thank you very much. It was quite a discussion today, and that's fine. Yep, that's fine. I'm going to, not that our committee reports are not important, but I want to get Jenny is here to give the report on the AAAs, and there's been some discussion today, and I want to hear from I4A today. So thank you, Jenny.
Sure, no problem. Okay, so I'm filling in for Hannah Carlock today. She's our interim CEO. She actually, yesterday they scheduled the Senate appropriations hearings for this morning, so she was testifying there. So I'm filling in for Hannah today. I am Jenny Hamilton. My, I guess, day job, I don't know how you say it. I'm the CEO of Livestream Services, which is the area agency that has, as Joanne alluded to, we have 2 PSAs. We have 6 and 9. And then I'm also the board chair for I4A. So I'm here in the capacity filling in for Hannah as the board chair. So I have a few updates from Hannah and a couple of late breaking things that came up yesterday that I'll touch on. First one is, of course, it's a budget year, state budget. So she is at the Appropriations Committee testimony today, this morning. Currently, Choice and the Dementia Outreach Specialists are both in House Bill 1001, however you say it. They're both in there and they're both at the same funding level as they were last year. So hopefully after today and after everything going on, they will stay there. We are working to maintain both of them. We would love to see the 12.5 million of Choice that currently goes to match waiver come back. We'll see. That was something I'll talk here in a minute about our day at the State House Tuesday. That's something we're working on, but at least to maintain the Choice as it currently stands right now is our goal. We do have the House Bill 1391. It's our choice bill. It did pass unanimously out of the House, and Chairman Barrett of the Health Committee said it was one of his favorite bills this session, so that's good. It's over at the Senate, so we're hoping to get that moving. Representative Clear, who authored the bill, and Hannah sat down yesterday. I know Aaron was there. I'm not sure if Kelly was there. No? Okay. So they talked yesterday about maybe some changes with the bill. One of the things in the bill is about decoupling services to give us a little more flexibility to divert people off Medicaid. Because I know that's a big selling point right now to keep choice is what it can do to prevent people from going on Medicaid. So there's talk about maybe looking at which services we decouple and which ones make sense to leave the same at the same rates and definitions. There's also a pilot Medicaid diversion program separate from choice in the bill. Thrive West Central and Terre Haute has been working with the Leo Center at Notre Dame on a pilot project looking at some chronic health disease management and some home modifications and how it can also help keep people from needing Medicaid assistance as quickly. And we were looking at another area to pilot that in, and we actually agreed to pilot that in Area 9, which is my area over in Richmond. So that is in the bill to pilot that in both areas to give another option as far as how to divert folks off of Medicaid or needing Medicaid as soon. And so we appreciate Aaron and the folks taking time to work with Hannah and Representative Clear yesterday. So we are hoping to work with Senator Charbonneau to get a hearing in the, I think it's called the Health Committee in the Senate. So we're working on getting that hopefully up and heard in the next couple of weeks. So that's our state update. We did have, I heard talk earlier today about Tuesday was Senior Day at the State House. So Representative Shackelford had organized that. She had a lot of vendors there and providers, and that was really great to be there. I think there were 9 of the 15 AAAs who came. I think I saw everybody at least passed them in the hallway and got to wave at them. But we had over 40 legislators that we met with. There was a panel. My theme this week is kind of being the understudy. I filled in on the panel for our public policy chair, Laura Holscher, who couldn't be there. So I was on the panel with SHIP, AARP, Social Security, who got most of the questions, I believe. So I got to do that on Tuesday. And then Tuesday evening, we had a reception where we were able to honor Representative Clear with our Legislator of the Year Award for his work on behalf of older adults and people with disabilities. So that was really cool to get to give that to him. And then last but not least, federally. So at the federal level, as you may have heard, there was this whole little budget thing going on. And so that the continuing resolution did get passed. Our programs and services under the Older Americans Act are level funded. So the good news is they weren't cut because sometimes they kind of get on that chopping block as non-defense discretionary. But at this point, we have current funding and we have level funding through September 30th. So next will be to kind of gear up for next year for the upcoming budget session that should start for October, for the budget that should start for October 1st. And I know Hannah, myself, Laura, and a couple of others are going to DC to our national organization's public policy update briefing in a couple of weeks to talk about what's going on federally. So does anybody have any questions for me? Man, I feel like I'm getting off easy. Wow. Go last. If you go last, nobody will ask you anything. Is that?
Well, I want to say it's wonderful to hear support for the AAAs from at the state level, and at least the level funding was kept at the federal level. The AAAs play a very important role in our public policies and government funding or government services. We hope you stay funded. You have to in order to carry out some of these things. And so I think it's wonderful you're not getting 1,000 questions today. I think we're all waiting to see what happens with the budget here in Indiana, and then we move forward from there with a number of things. So really appreciate you coming and giving us this update. And anyone have any comments, questions, thoughts? Wonderful.
That was
Thank you
easy.
so
Okay.
much, Jenny, for coming. I'm going to ask these advisory committees, I think are very important. Just talking about the Living Longer, Living Better Collaborative, I've been waiting for the budget to get finalized here in Indiana before I call that group together again. And I know some of you offered to be on it the next time. I'm waiting till all of that happens. And I'm very much focused on, we worked on this earlier here, Living Longer, Living Better guide with the commission. And we're very focused on some community care coalitions within local communities to help them at a local level get organized. That was our way we approached this. We'll get back into some of that, and it ties in with the multi-sector plan on aging, with dementia care, et cetera. So we'll get that going. Anything on the shared decision making? Anything?
No,
Judith?
we're on hold until
Till you get
the APS gets figured out.
okay, and we'll hopefully get some information on that in May. Emergency housing, Deb?
Shock of all shocks, we're on hold until APS gets straightened out. So, yeah.
Okay, very good. Kelly, family caregiving?
No substantive updates from our last meeting. We are scheduled to meet next week. So the next meeting, we should have some updates.
Great, thank you. Housing supports, Dan, are you on? So if he's not on, we don't have housing supports or the Senior Center Coalition of Indiana. I think they are meeting soon if they haven't had their major state meeting for the year. Okay, very good. Well, we've had quite a morning, but it's good. I hope everybody's kind of seeing we all have to get in here and just keep on going. And so our next meeting will be in May, and we should have a little more clarity. We will have clarity then on our budget and move forward. So, okay, happy spring, everyone. It will get warm in Indiana eventually. Have a good day. I am going to call our meeting to a close. So meeting is adjourned.